We have 15 minutes for questions. If I can ask you, just keep them short so that we have enough time for everyone to have an opportunity.
Good morning. Thank you. I think the conversation is so enlightening, and I just want to share an observation. As you know, I'm with CMS, and one of the things we're trying to do is determine what words do we use to designate the individual we're trying to care for, and that name changes over the spectrum of care. And I think we can undergo a radical redefinition and rethinking of who our end user will be if we truly get away from the word patient. It's a preset, predetermined definition. I think we need to get to person-centered care.
Right.
Maybe a minor shift, but it's important.
Well, we appreciate that. Actually, that was a topic in our committee work as well, and we came to person-centered care as compared to patient-centered care. So thank you for that. We'll go to this.
Hi, so my name is Erin Board. I'm a fourth-year med student at the West Virginia School of Osteopathic Medicine. And so from my perspective, all of like 2 years ago in med school, this week it was like the saddest week in med school, where all we did geriatrics and end-of-life care and palliative care. I think they threw suicide into that week. It's a very sad week. And we also had a standardized patient, and all we had to do was go in there and tell them that they were going to die. And it was really hard and sad, and everyone was crying. And then that's where it ended. And I'm just wondering, I know you're with the AMA and there are different licensing organizations, but it wasn't something that I was ever tested on again. And we have, as part of our step 2 boards, the clinical skills or the PE, and it's not incorporated into that, where I mean, we are tested on our patient bedside manner, but we're not tested on, can we have that conversation? So I was wondering if you could talk a little bit about
Absolutely.
that.
Steve or Ryan?
Sure. I think you bring up an excellent point. And one of the problems with the whole evaluation system is that it often focuses on either tests or simulated cases. And the issue is what people do in practice. And I think that there is a lot that we need to do in terms of faculty development for this, so that faculty know how both to teach and how to evaluate students and residents in their care. And this is something that needs to be really incorporated into the bedside teaching with actual patients. That's the critical part. I just don't think you can do it in the simulated environment necessarily, or in the training of it. You can do some of it in simulation as the sort of the initial part of it, but you can't just stop with simulation. That's really more the point that I'm saying.
I think the thing is that, look, you want to be a good physician, and it's not you want to be a good test taker. So, the fact that you're not tested every time on every part of what you want to do as a good physician, I think your goal should be to be a great physician that takes care of patients and not somebody who passes all your tests. Your view of tests should be just simply that's how you demonstrate what you know and you can do, but you shouldn't be saying, I'm going to take that test so I can demonstrate that I studied for that test. And I think that's one of the things that we have to be careful with in the evaluation process, that we don't let the test drive what people end up doing. The test is just there to validate that you know and can demonstrate that you've got the training you need, but don't specify whether you were ever tested on again must mean it's not important. It is important that you be a good physician that takes good care of your patients.
Just that the focus on the tests, it allows for the development of skills. And that's, and that I think that's just a means to an end. Like, it is hard and it shouldn't be all about the test.
Yeah,
but just
I agree. And I think the other important point is that the actual measurement of impact should never just be on the provider. What I'm really interested in is, how did the family do at the end of this? How do they feel a year, 5 years down the line? Because that is what we should really be measuring as well. Okay, thanks.
Well, from the other end of the physician spectrum, I'm Vitor Friedman. I'm a board...
Can you speak up a little bit?
Sorry. There we go. Okay, so I'm Vitor Friedman. I'm a physician. I'm on the board of the American College of Emergency Physicians. So I'm a little bit different spot than our last speaker, and I would like us all to congratulate the fact that she had any training in this discussion at all, because when I was in medical school in the 80s, we did not. The expectation was that we would know how to talk to patients about dying and terminal illness, and we had no training at all. So there's been an evolution. We need to go farther. A comment. You asked, what are we going to do in the next year or two? What are the panelists going to do? What are their organizations going to do? I would ask us to focus on the critical issue, which is that we have to find a way to make this conversation part of the normal medical care of the patient.
Absolutely.
And so while there's a lot of things that people have brought up, the reality is that this conversation needs to happen, and it needs to happen early. It needs to happen when we're not ill. We need to think about this as a country and as a society, and that should be the focus of our efforts. And if we can get the conversation to happen, and then happen earlier and earlier and earlier, I think we win.
Right. Yeah, I think that's a really valuable point. And one of the things that we came to in our work was having these conversations as part of the life cycle. And we were very specific in suggesting that they begin occurring when you're an adolescent, maybe even earlier than that, that they take place when you get your driver's license or get married or take on a new job or move or have an illness, and certainly that they take place around Medicare. But I think the danger that we've gotten into is we think of the conversation as a static, singular event, and it's usually a cataclysmic one as compared to one that has had some history around it and some approximation that changes over time.
I would agree with you 100%, but I think if all of our organizations could focus on that goal, and that we were united in focusing on the goal of implementing the conversation as part of the normal medical conversation, when you see a physician or a provider throughout your life. I got a new primary care physician a couple of months ago because my old guy retired, and I realized that neither one ever asked me if I had an advance directive. And I do, but neither one of my physicians knew that.
Yeah.
Because it's not a part of the normal conversation.
That's right.
So.
And so it's not only a matter of having it happen, it's a matter of, to your earlier point, educating people to be able to do it as well.
Right.
Okay, thank you. To the next microphone.
I'm Türkan Gardenier from Pragmatica. Both my husband and I have worked as statisticians in the health field for over 2 generations, and we're delighted to be part of this group. What I wanted to emphasize, as has been mentioned before, is the time-varying element in the metrics of hospice. Scott Shreve indicated that as cases in point for Veterans Administration benefits, and I'd like to mention another case in point where if a friend of the family had private duty assistance in her later years, but when the caretaker left to attend to an emergency back in her country, our friend went into the hospital, got classified into hospice, and when she was sent home, the caretaker came back, took good care of her, and her hospice status was discontinued. Then she couldn't get any Medicare benefits, and there was a hassle in terms of getting any financial assistance for her in her later years. Since that time, she lived another 5 years with good care from the caregiver. So the metrics involved in the hospice classification could be modified or perhaps changed, taking into consideration the time-varying elements of the metrics.
I'm not sure I understand exactly your point, but if I could just say, in the Department of Veterans Affairs, we consider hospice and palliative care a big continuum. Okay, there's no forced choice. So does anybody know what's the one reason it's an advantage in the VA to say you're getting hospice? It's probably the only advantage. Anybody know? Yeah, I didn't think you would know. You're exempt from the copay. And that was the law. And so I just want to let you know, so it really doesn't matter in the VA system anyway. You get palliative care. Oh, you want to call it hospice? It's okay. You call it whatever you want. It's this big continuum, and it doesn't change anything else. So anyway.
Yeah.
Right.
So,
And that's the point I thought you were getting at. I think Don
wonder
may
if
want to make a
Donald
comment
would like to make a
about the
comment about that.
elimination
Donald,
of
do you
the
have
6
a
month.
perspective?
The one thing I just, what you mentioned a little bit earlier in terms of what we would change, we are committed to expanding the hospice Medicare benefit, therefore eliminating the 6 month or less criteria. That is a big part of what we do. Glacially, Washington will move very slowly on this, but it is a part of our goal and part of our public policy agenda to expand that benefit. The concurrent care model that is being demonstrated by Aetna and several of the other insurance companies right now is really giving us, I think, the path to the future, and we're very excited about that.
I mean, it's almost an essential thing to accomplish. I mean, the fact that hospice is 8 to 18 days of utilization is just a terrible situation. So the fact that we let that linger just makes no sense.
And at the very beginning, there was no time limit on the hospice Medicare benefit in 1982 until David Stockman said, this is too lucrative of a benefit. We have to put a time limit on it, and that's when 6 months.
Right, so is everybody in this room in favor of changing that policy? Do that in a year.
Yeah, sure. Good luck with that. Yeah, good luck. My name is John Mulder with the Trillium Institute in Grand Rapids, Michigan. I've been practicing palliative medicine for about 30 years. And just a quick comment about the quality issues, because some of the comments suggested that we don't have them. And actually, as Don would attest, they've been active, the NHPCO, for decades in working with partner hospices to develop and implement strong evidence-based quality metrics. And additionally, just 1 month ago, there was a publication, Journal of Pain and Symptom Management. It was a kind of a white paper that was produced through the American Academy, Hospice and Palliative Medicine, and the National Hospice and Palliative Nurse Association, excuse me, which outlined measuring what matters. These are evidence-based 10 top quality measures which are accessible, they're implementable, and hospice and palliative care organizations should take a hard look at those and look at implementing those, and then hopefully governmental organizations and payment sources will look at that and say, aha, they do get it, they do measure it, it does make a difference, and it's really good stuff. So that was just my comment.
Great, thank you. So we have time for just 2 more questions. We'll take one on this side and the last here.
Arnold Iser, Philadelphia. I appreciate all the comments by the panelists, but one thing that's missing from this morning is any discussion at all of geriatrics. There is an excellent article in this month's Health Affairs. It's under the Narrative Matters by Louise Aronson, and she nicely describes what a geriatrician can really change the paradigm when they enter the picture. There's just as the population, the geriatric population is growing exponentially, we have decreasing numbers of geriatricians. Does anybody want to comment? Steve, maybe?
No, this is, unfortunately, Chris had to leave, and I'm sure Steve will want to comment, but I'll offer one perspective, which is, this has been part of a much broader issue in medicine, the disincentives to go into areas like primary care, geriatric care. It has everything to do with the way those fields have been viewed traditionally, and in point of fact also how they've been compensated. And I think until we begin to change that, we're not going to really see significant progress. And yet, this is one of the most important areas that I agree with you that we can seek to accomplish.
And I'm not a geriatrician. I'm a nephrologist.
Arnie, I think you bring up a very important point. And what people say is geriatrics is the one field in medicine where the more training you have, the less you get paid, which I think is tragic. And I think to some extent what we need is kind of more role modeling and incorporation in the curriculum.
Right, but I would further argue, just as in the broad field of healthcare provision, I don't think we necessarily need more doctors. I think we need more healthcare providers, and I would love to see more nurses and others really engaged in this area. Pam, would you like to comment
Yeah,
on
actually,
that?
I was just going to comment. First of all, geriatric nurse practitioners can provide the very care that you're saying, and they often are the ones who are thinking about palliative care and hospice care much sooner, and again, are able to provide the coordination of that care. One of the other things that we're doing extensively is really looking at where we're pivoting to move care out of the hospital and recognizing so much more care is going to be given in the community. So we're collaborating with any number of groups to really look at the access issues and having the right provider in the right place.
Great, thank you very much. Okay, last question.
Hi, thank you. Paul Tatum, University of Missouri. I'm here with Hospice Compassus as one of their medical directors. I'm on the AHPM's policy committee. I should say thanks for all the shout outs to AHPM and HPNA from the panel. I think they do important work. I'm thinking of a friend of mine, a small town doc in Missouri, and he wants to be a powerful hospice person to help take care of patients in his region as they're aging. And he's 50 years in practice as a primary care physician, well, 50 years old, and he's done a great job. And as we talk about this education, that's a big transition for him. And I think you've talked about with the AMA, Dr. Waugh, some of the resources there, but that's a transition skill set that's a different way to practice, a different way to teach. And I wonder how you would envision that mid-career physician who really wants to do this more resources. I would encourage the Pachita Bill, the Palliative Care Hospice Education Training Act, as one way to do that, to create regional educational centers to reach that mid-career pathway. But what about that guy that doesn't know he needs to do this better?
Yes.
I guess you bring up a thought in my head about, on a broader level, one of the three major focus areas for the American Medical Association is professional satisfaction and practice sustainability. And I think in that umbrella, we talk a lot about not just how do we allow physicians to just barely survive in their practice, but how do we make them thrive. And one of the aspects of that is, in fact, how do we look at transitions and how do we look at giving them the tools that they need to make the kind of changes that you're talking about. There's a whole bunch that goes on beyond that, the regulatory burden, the administrative burden, the financial burdens. But you bring up a good point about how do we facilitate or how do we help physicians that want to make a transition in their career of any type, right, whether it be from direct clinical practice to another aspect of care. I think there are opportunities in that area, and I think there is some interest if people knew that there were tools out there to help them. Yeah. And so we're going to be putting out some tools to help on the administrative and regulatory burden side of it, but I think you bring up a good point that there may be an opportunity to think about other tools that we can put out there. So thank you for that.
Well, I appreciate that, and I would, yes.
I was going to say, let me just add a couple of things. So as you've heard Chris talk about the quality measure development, until we can develop more outcome-based measures that look at not only what right now is primarily measured as physician-delivered care, but team-based care, and provide that feedback. I mean, I think that's going to be a critical step in really looking at not just checking the box in terms of what we're doing. And so I think that's an element as well. And then I think the other thing in terms of looking at more patient measures or patient experience measures. Groups like Prescani are working on understanding, again, these causes of suffering and being able to get measures that look at the patient experience across the continuum of care. And so not only just the measures like HCAHPS and things like that, but I think we're going to get informed with a very different focus on quality measures that will help bring perspectives into play.
Okay, well, thank you very much. Thank you to the panel for wonderful comments and to the audience as well.